Thank you, Chairman. Good afternoon, ladies and gentlemen. The topic given to me today is the management of recurrence of HCC after liver transplantation. This is my disclosure. And I think there are three possible mechanisms of HCC recurrence. First is subclinical extrahepatic spread that may exist before liver transplantation. That's why the selection is important. And secondly, it is a nesting of circulating tumor cells shed during apoptectomy. So we have to do some minimal handling, and it's better to do outflow occlusion before mobilization of the liver, like cancer surgery. And then third one is the immunosuppression. Maybe it has low impact in the recurrence of HCC, but it may be more related to tumor progression. I will show the typical clinical feature of in patient of recurrence of HCC after liver transplantation. This patient underwent DDLT January 2016, and then just 4 months later, the recurrence was found in the liver and lymph node, and sorafenib was given, but it progressed, and it metastasized to brain, lung, bone, and expired in 1 year after liver transplantation. And most of patients who had a recurrence very early time after liver transplant show this kind of a bad prognosis. But we have a different situation. This man underwent LDLT in 2008 February. It was okay, but recurrence was found in the brain, and this brain lesion was eliminated, so was resected, and some RT was done. But 2 years later, adrenal gland metastasis was found. We treated with this radiotherapy, and also lung recurrence was found. We treated with sorafenib or some chemotherapy, and this patient is still alive after 7 years, 5 months after liver transplantation. So definitely, it has some bad prognosis in patients with recurred after liver transplantation because of you already have information from previous speaker. But some patient has very good prognosis with appropriate treatment. Maybe biology, tumor biology is very important in this kind of patient. We have a consensus conference in 2011 in Swiss, Zurich. It was hosted by Dr. Karabian, and this is the result of a consensus conference. And as you can see, this management of HCC recurrence after liver transplantation has very weak evidence, and it is not much recommended. So, but anyway, the liver recurrence was found usually 5 to 30%. And in 2 years after liver transplantation, median recurrence rate in systemic analysis showed that 16%, and median time to liver transplantation to recurrence was 13 months. And we can usually found in liver, lung, bone, followed by adrenal gland, lymph node, and brain. So we can use any management in just like in primary tumor when we use in primary tumor, but as a previous speaker said, is immunotherapy mTOR inhibitor is important because it has a immunosuppressive effect and as well as anti-cancer effect. This study showed the long-term survival after recurrence of HCC in liver transplantation, and they studied the 16 liver recipients developed HCC after liver transplantation. The recurrence was found in lung, liver, bone, cerebellum, adrenal gland, and peritoneum. And they found that that liver transplantation with the recurrent HCC amenable for surgical therapy has a significantly better long-term survival than a patient with a tumor is not suitable for the surgical resection, although the number is very small, and they found in multivariate analysis that late tumor relapse and surgical treatment were the prognostic factor. So in patient with the recurrence in the liver, it is very hard to actually dissect the liver recurrence. But if it is an effective treatment in selected cases, and the prognosis factor is a large tumor, good tumor differentiation, and absence of bony metastasis. And the lung is a special one. I have several patients who underwent lung resection after and in 2 or 3 nodules, and then they have NED after that kind of surgery. So it's a good response. Also, Dr. Huang showed that radiofrequency ablation in liver recurrence showed a similar result with a surgical result. What about the taste and tear? And one study showed that 67% of patients has shown some response. By 25% or more is showing some response. And then recently, some radioembolization is become popular, and they show the similar response between two THE and TARE. This study showed the comparative effect of sorafenib versus best supportive care. And then in this patient group, the 44 patients was included in the study. And from the beginning, 9 patients cannot offer any local regional therapy. And 35 patients underwent some local regional therapy, but 30 patients recurred and progressed. And 39 patients who had unresectable presentation progression. And group 1 is best sorafenib group. Group 2 is the best supportive care group. And they showed that sorafenib is effective in after recurrence when you use sorafenib in the patient who recurred patient. So sorafenib showed some benefit, but it is another study, recent study from Assam Medical Center, and they showed that sorafenib use was not effective between 2 groups, sorafenib positive, sorafenib negative, but mTOR showed some difference between 2 groups. So, and then sorafenib plus mTOR also has, sorafenib has no effect, but mTOR is more important in improving post-recurrent survival. So this study is a systematic review published recently, and then you can see that surgery is the most effective therapy. Median survival is 42 months after recurrence of HCC, followed by sorafenib plus mTOR and sorafenib and TACE. It is this result is much better than best supportive care, only 3.3 median survival. I just showed the result of our study, our center from January to December 2015. 532 patients underwent a living donor liver transplantation for HCC, and 17.3% patient, 92% had recurrence. And then you can see the demographics here. Age is 53, man is predominant. Still, we have a HBV very frequently. And PET positivity of the tumor was 40%. And beyond Milan is more than half. We don't use a Milan criteria in our center. And then multiple tumor was found in 40%. Even microvascular invasion was present in 17 patients in this patient group. And then mTOR was used before recurrence was 30%, but after recurrence we used the mTOR inhibitor in 71 patients. And then various treatment was applied. And then recurrent site was a liver, lung, bone was a frequent site. And the multiple organ was involved in 25%, and the multiple tumor was found in 65%. And this slide shows the survival curve after recurrence. As you can expect, the survival was bad. 1-year survival is only 59%, and 5-year survival is 11%. And then this is the prognosis factor. As you can see in multivariate analysis, PET scan positivity and time to recurrence was and organ involvement, multiple organ involvement was a bad prognostic factor. And so we divided the patient into two groups, early recurrence group, late recurrence group, by 6 months, and early group and late group. And if you see the prognostic factor in patient who had early recurrence before 6 months, in multivariate studies showed maximum size and location of recurrence, and then multiple organ involvement was a significant factor affecting survival. But interestingly, the prognostic factor in later recurrence group showed that only an mTOR inhibitor uses, it has a significant benefit, in and organ involvement. So this slide shows the mTOR survival in patients with the mTOR inhibitor according to the multiplicity of involved organ, and if single organ is involved, mTOR inhibitor is much better effective. And then resection is also show that if it is single organ, resection is show the much better survival rate. So in this study, we can summarize that surgical resection should be considered in case of late recurrence, especially in case of late recurrence involving a single organ, and mTOR-based immunosuppression should be considered in recurrence case, especially in late recurrence case. Lastly, I'd like to show the immune checkpoint inhibitor. It is now effective in some patient with HCC. We have a CTLA-4 inhibitor and a PD-1 inhibitor. But we have to be careful because this kind of immune check inhibitor has showed some activation of immune system. So it may cause some rejection in this patient. Several scattered reports now, we can see that there is a various results, some are very effective and some show some rejection. So we should study more about immune check inhibitor uses after recurrence in LDL in liver transplantation. And another thing we have to consider is immune cell therapy. We have some therapy, cytokine-induced killer cell or some NK cell. This cell is ex vivo expanded autologous T cells. And then this is adjuvant therapy after RFA or resection. And we show that CIK therapy has a better disease-free survival and better overall survival. It was published in Gastroenterology 2015. It is only study to show some benefit of adjuvant therapy after treatment of HCC. And so this kind of therapy is effective in small remnant cells, small cancer cells, small number of cancer cells. So this kind of thing, subclinical extrahepatic spread or nesting is a small cell remnant problem. So maybe we can use immune cell or some NK cell to remove this kind of thing, and then we can have a better result after liver transplantation. As you know, the AP-HBV, Asia-Pacific HBV A 2019 will be held in Seoul, Korea. Please mark this date and please visit our city. And in conclusion, surgical resection should be considered if possible, especially in late recurrence group with the use of mTOR inhibitor. And although challenging management of HCC recurrence in LT patient can be improved with some multidisciplinary approach and a new type of therapy. Thank you for your attention.